Hello, I'm Janice Karen, Director of Policy, Technology, and Innovation at the Massachusetts Health Data Consortium, also known as MHDC. I run our Data Governance Collaborative, also known as the DGC. We start each of our weekly meetings with a series of industry quick updates to learn about new and proposed regulations, laws, standards, industry initiatives, and other activity. Join us for this week's updates. All right, so we've been talking about TUFCA releases for several months. They've been kind of staggered. The next tranche of TUFCA standard operating procedures was released yesterday. There are 5 of them, 2 of which are completely new, and 3 of which are updated versions of existing standard operating procedures. We've not had a chance to look at them yet. There are still at least 5 more that are expected this summer, so there will be at least one more group of documents released. And you can find out more information and get 2 copies of the new SOPs and documents at the link there. Any questions, comments, thoughts, concerns? All right. So bear with me. ASTP, the former ONC has decided that the short version of their name will be ASTP and not ONC. So it'll take a little while to get used to that. But HTI-2 proposed rule was formally published in the Federal Register on Monday, and the comment period has now been established as closing on October 4th, which unfortunately is the second day of Rosh Hashanah, which means there will be 2 fewer days in which to finish our comment. But such is life. There may be some minor adjustments from the pre-publication versions that we've been reading and reviewing so far. In that case, the official published rule wins, so we'll definitely be looking at even stuff we've already read in the officially published rule. And also note that the rule itself still says ONC and not ASTP, ONC, or ASTP. So that may also filter into any slides or conversation we have. So you can find the formally published rule at the link below. Any questions, comments, or thoughts there? All right. So next, CMS has posted its inpatient payment rule, the final rule, and it's officially going to be published on August 28th, and pieces of it will go into effect on October 1st, with some pieces going into effect on November 1st and others on January 1st. So some of the key changes, one of the ones that I found particularly interesting, is that they've changed the way that they're going to be dealing with housing insecurity and homelessness. It's always been something that's been reportable, but it's now going to be treated as a comorbidity for a reimbursement perspective. So certain treatments and services for people who are housing insecure or unhoused may be reimbursed at a higher level because of an understanding that it takes more resources to serve that population. So I thought that was interesting. Most of what I looked at in this rule was the quality measure changes. There are some changes to the hospital-specific quality measures. There are 9 new measures, including 2 new ECQMs. 5 measures were removed, one of which was replaced by a broader measure. And there were also modifications to 2 of the existing measures, one of which was a set of changes to the patient experience and related survey measures. They also have started increasing the requirements to use digital quality measures or ECQMs. There will be 8 required in 2026, 9 in 2027, and 11 in 2028. And also ECQM data validation will start being a thing in the 2025 reporting. Any questions about those before we go on to the second page of this? Okay. So then for the Promoting Interoperability program, there are also some key changes there. Excuse me. There were some definitional changes to match up to what was in the information blocking provider disincentive rule that was finalized earlier this year. And then they also made similar changes to the qualifying quality measures and increases to the mandatory digital quality measures. So the antimicrobial use measure was split into 2 new measures. And then there are also 2 new hospital harm related digital measures that are in the optional measure set. And they also made the same changes to the mandatory numbers that were on the previous slide. The other thing that they changed, which we've known was coming, is the required performance threshold for getting credits for promoting interoperability program. And in calendar year 2025 reporting, that will move from 60 to 70 points. And then in calendar year 2026, that will move from 70 to 80 points. That last move in particular is interesting because there are some components that have been discussed. I don't remember off the top of my head exactly what they are, but I know there are some places where failing to do one thing that's part of the promoting interoperability program will will lose you 25 points. And so unless they restructure some of that at the same time, there are some interoperability pieces. There were specific interoperability requests or requirements to get points. And so there are some things that are technically optional now if you're willing to take the hit on points. That would mean that you would automatically drop below the required performance threshold if you didn't do them starting in 2026. And I apologize, I can't remember what some of them are off the top of my head, but if folks are interested, we can go back and try to look those up. There were also some changes to value-based care programs. So you can find the final rule at the link below, and anyone have any questions or comments or thoughts about any of that? All right. So there's a similar, now at the proposed rule phase right now, physician fee schedule. So that proposed rule was posted on July 31st, and comments for that are due by September 9th. So not a huge time period to comment. So there's a lot of stuff in that rule. Again, we focus on quality measures and interoperability programs. And so there is a new AMP Performance Pathway Plus program that has 5 additional measures to incorporate the entirety of what CMS calls the Universal Foundation Measures by 2028. And there are also some updates to MIPS, measure and activity inventories and scoring methodologies. I focused on the measures. So here there are 9 new measures, but they're getting rid of 11, but they're changing 66 of them. So there are a lot of changes to the measures in this program. They're also adding a bonus for what they're considering complex organizations. So qualifying organizations that meet data completeness and case minimum requirements will get some adjustments that give bonus points. And in total, the total of the bonus points for all of the qualifying stuff cannot exceed 10%. Another change that they're making is that if you don't have at least one numerator and one denominator for a quality measure, then it gets assigned null. In the past, sometimes those got assigned zeros, and so they counted against people. So that's sort of an attempt to not ding people for things they don't have data for, although it doesn't change the actual requirements around the number of measures that people need to do or things like that. So any questions on that so far? Okay. So moving to MIPS in particular, one of the things that they changed is that in the past they used the highest. If you submitted multiple times throughout the period, they would use the highest scoring submission. But now they're using the most recent one. So if you're doing multiple submissions for MIPS, if you're a provider, then you want to pay attention and try to ensure that you're not decreasing your score by submitting new data, assuming that that new submission is optional. obviously, if there's something in it that you're required to send, you have to send it. So starting in submission year 2025, they're also putting in specific requirements about what the data submission has to include. And so it has to include the specific data that's listed here. And again, this was promoted as a way to ensure that incomplete data is less detrimental, or data that might have been submitted accidentally. So by including this data, there's a sense that this could not have been an accidental submission. I don't know if that's a reasonable thing, either from the assumption standpoint or if there's even an issue around that, but that was sort of the rationale they presented for why they were doing that. So any questions, comments, thoughts here? All right, here's the really interesting one. This is, to the best of my knowledge, the first court case that involved information blocking. So there's a federal judge who has ruled against PointClickCare, which is a big EHR company that's used for long-term care, if I remember correctly, post-acute care. And they were sued by a vendor called Realtime over the improper use of captures that make data access impossible. And PointClickCare indicated that this was a standard practice used to prevent bot access, but they were setting up the captures so that they could not be solved, so there was no way to get past them. And so last week, a federal judge ruled against them, and explicitly citing the 21st Century Cures Act several times, as well as talking about anti-competitive business practices as the main drivers in the decision. So just to give you a sense of, there was no evidence. So the information blocking rule lets you not comply if you meet an exception. And the judge has said there's no evidence that there was any reason for that. Security would be a reason for that. But the judge has said there's no supporting evidence there's any legitimate good faith use for doing this. And that captures that they were using, by definition, blocked the vendor company Realtime from getting any records, and they need those records to continue existing as a company. And then apparently the context behind that was very interesting, because at one point, PointClickCare was had some M&A talks going on. I don't know if they were looking to acquire them or merge. There were some discussion of joining the two businesses in some way, and PointClickCare cut those off. That's when they changed put in the unsolvable captures that shut down apparently 700 of the 1,700 facilities that Realtime was using PointClickCare, where Realtime needed to access PointClickCare to work. And they did that overnight. And so the judge has basically said the timing of the deployment support that they were basically being used to hamstring Realtime as a competitor. It's a really interesting case. I haven't seen a ton of detail. Most of my information came from this article that was linked, but for those of us who are looking at interoperability and the way information blocking might work in reality, and the fact that it's not just declining to do a specific request, but also, this was one of those cases where it was an IT decision that was made by the software that prevented the access. And, we haven't talked about it a ton, but the rule does explicitly say it doesn't have to be, someone asking for a specific piece of data and getting denied that specific piece of data or not engaging, but it can be a systemic, it can even be a systemic reason. So if they were to put this caption generally, that would be a problem regardless. So I just thought this sort of touched on a lot of different areas that I thought were really interesting around the way interoperability rules and rulings might happen, and some of the behaviors that might be invoked, and how those might get reacted to. So I don't know if anyone else would like, I don't know if maybe other people don't find this as fascinating as I do, but I really found this very interesting, and I don't know if anyone else would like to comment on it at all. All right, well, I'll be keeping an eye on that case, and maybe others like it if there are others like that in the future. For now, moving on. CMS has opened up a measure preview window for 2 of their hospital quality measures. So the patient safety indicator measures, which contain data from July 1st, 2021 to June 30th, 2023, and the severe obstructive complications electronic measure, which has data from the calendar year 2023, are now available for preview, assuming that data was submitted prior to March 2024. And so hospitals that submitted data can review the results until August 29th, and they can ask questions about the calculations. And if you're going to do that, you have to include the information that's listed on the slide about your organization, including both organizational information and a contact information. And then also a note that none of these questions should include any PHI or PII. They will be publicly visible in some way. So this came from an email, so there is no further information, but if anyone has any questions or comments or thoughts. All right. So CMS has put up a new fact sheet explaining a really high level thing about administrative simplification, sort of what it is and what it's meant to accomplish. It's a single sheet PDF. It might be a good wall poster if anyone's looking for something basic in that. It's not quite an infographic, but it has a similar feel, and you can find it at the link there. I'm just going to move on from that one. There's not really a ton to say. The Kaiser Family Foundation has a new Health Policy 101 website that gives their take on basic health policy issues and sort of how to. I don't think it's not so much opinion as sort of informational. Their take on it, their take on what's involved in them, as opposed to necessarily opinions on them, if you understand that distinction. So these are not all of the topics that are covered, but these are some of them. And I thought the second to last, I thought it was interesting when they talk about polls. That's not something that is necessarily, it's something that exists, but I don't know that I've seen any real explicit discussion about it. And also they really tie into, they made an effort to tie in the global health issues, which obviously that may be a result of the pandemic more than anything else, but that have always been part of health policy, but don't necessarily, unless we're in the middle of or recovering from a pandemic, get highlighted too much. So if you're interested in taking a look at what they have to say, you can find the link on the slide. Any questions, comments, thoughts there? All right. I hope you learned a lot from our quick updates. If you're interested in finding out more about the DGC and its other activities, email me at dgc@myhealthdata.org. That email address is also on your screen.